Hello, and welcome to the Alabama Public Training Network. Children have a unique vulnerability during natural disasters. They can feel very frightened, and afterwards, some children can even have temporary changes of behavior. Today, we will take a look at the information learned from real-life events in Alabama to highlight the hospital, state, and regional level coordination efforts on behalf of children. Thank you for joining us today for our program, the Emergency Management Safety of Grand Rounds, Children and Disasters. Our objectives for today are to state the elements of personal and family preparedness for disasters, review hospital disaster planning and response for incidents involving children, and to provide an update on the state, regional, and national preparedness efforts for children in disasters. If you have any questions today about the content that we cover, please call us or email our faculty presenter during this live broadcast. The phone number and the email address will be on your screen, and it will appear later on in the program. Also, the handouts, sign-in sheet, and evaluations are all available online. You will need to register for this program in order to access those materials. Continuing education credits have been approved for nurses, social workers, and emergency responders for today's program. The Alabama Department of Public Health is an approved provider for continuing nursing education by the Alabama State Nurses Association. The association is an accredited approver of the continuing nursing education by the American Nurses Credentialing Center Commission on Accreditation. In order to receive credit for this training, you must watch the entire program. Then complete and return the sign-in sheet and evaluation tool. Instructions on how to do this can be found at the bottom of the sign-in sheet. While content may continue to be relevant, CE credit will only be awarded for 2 years from today's date, which is July 29, 2014. There is no financial responsibility between the planners of this program and the speaker. There is also no commercial support for this program. The Alabama Department of Public Health does not endorse any product that may be displayed in conjunction with any activity that might be demonstrated, nor will the department discuss any off-label use of products. As a reminder, the content of this program is based on the policies and procedures of the Alabama Department of Public Health. Alabama and federal statutes, rules, regulations, and guidelines. Viewers are not employed by the Alabama Department of Public Health should always check to clarify whether the content is accurate according to the statutes, regulations, and policies of your respectful jurisdiction and or agency. Hello, my name is Teresa Dix, and I am a nurse educator with the Alabama Department of Public Health. I would like to introduce our speaker today, Dr. Mark Baker. Good morning.
Thank you. Good morning. Thank you, Teresa. Getting started today, I'll just say that I have no financial disclosures. I will tell you in full disclosure that I work also as an intermittent federal employee, and as such I have to just tell you that the views that I express are my own, and they don't represent those of any of my employer, including the Department of Health and Human Services or the National Disaster Medical System. Having said that, we'll start in. So, very basically, what is a disaster? A disaster is any event that exceeds the capability of the response. So, most typically these occur during natural disasters. And natural disasters probably are increasing worldwide. This is multifactorial, probably due to more people living in fragile environments and increasing the complex technologies, and probably climate change also. So when the events exceed the capabilities of the response, that's when you have a disaster. And I'll go over the emergency management cycle. Basically, the emergency management cycle involves four phases. The first one is preparedness. Preparedness involves all those activities we do to get ready for the coming of a disaster. And then this is followed by a response phase when you actually go and take action to save lives and property. Finally, there's a recovery phase at some point. And the recovery phase is where the environment is rehabilitated, the community's restored back to its baseline condition or near normal condition, and then a mitigation stage. And a mitigation stage or a part of the cycle involves reducing the risk for future disasters. So you have preparedness, response, recovery, and mitigation. It always goes in that cycle, and communities are always at some portion of the cycle. And so it's a continuous cycle that leads to an improved ability to respond to disasters. So how do governments respond to disasters? Well, we say that all disasters are local events. They start locally and they end locally. And as the capabilities of the response are exceeded at the local level, more and more resources are called in, first at the county and then state level, and finally at the federal level. And that as the disaster enters into the recovery phase and the mitigation stage, then it goes back to the community. So it's scaled back. So this is always something that occurs. They start locally and end locally. In terms of disaster response, there's a couple of key concepts that I'll go over. And some of this may be basic to people, but it may be new to other people. The National Incident Management System is really a comprehensive, nationwide, systematic approach to managing disasters. It involves a core set of doctrines, concepts, and terminology, and organizational procedures that all agencies that are responding to disasters have a common operating system to go from. The next thing is the Incident Command System, which is a on-scene management system for how disasters are managed. Essentially, this involves an organization that is put in place and is scalable and flexible and occurs on the scene of a disaster. So that's one of the core concepts of the National Incident Management System. How the federal response occurs and how states respond to disasters is really dictated through what's called the National Response Framework, which is the overarching federal guide for how disasters should be managed. They break the response into what are called emergency support functions, which are things like firefighting, mass care, sheltering, and then public health and medical services, which is ESF 8, which is probably of greatest concern to most of the audience. So emergency support functions are all spelled out under the National Response Framework. I told you that all disasters are local events. And again, most of the planning for disasters occurs at a local or county level. So county and states all have their emergency management agencies, and they develop plans that are specific to their community, how they'll respond to a disaster. And this goes up to the state too. And the states have plans for specific response and also how they'll interact with other states and other agencies. And then finally, there are a lot of agencies, volunteer agencies, that are active in disasters, and these are helped. The coordination of these is brought about through what are called VOADs, or voluntary organizations active in disasters. So sort of coordinating councils to help manage the community response to disasters. So what are the things that are the major threats? Well, it really depends on where you live. Here in Alabama, it is primarily severe weather, and that means tornadoes and hurricanes. Typically, there are about 6 major hurricanes that hit the eastern seaboard and the Gulf Coast of the U.S. each year. And tornadoes, on the order of about 400 tornadoes throughout the U.S. annually. This varies from a low of around 100 up to over 1,000, depending on the year. So severe weather is our major threat here, but depending on where you live, it can be other things. So this is a picture of a transportation accident in South Carolina that caused a chlorine spill. This occurred back in 2005. So chemicals are being transported across rail lines and roads in every city throughout the country. So transportation accidents are always a consideration. The bottom picture is from the Tokyo sarin outbreak or terrorist event. And terrorism, although rare, is always a constant threat that agencies have to prepare for. Flooding, fires, and domestic terrorism are kind of displayed in these 2 photos. Floods are the single most common natural disaster in the U.S. These primarily cause property destruction and displacement of population rather than civilian casualties. A couple more photos on transportation accidents and earthquakes. If you live in California, earthquakes are probably one of the major hazards, but here in central Alabama, relatively rare events. About every 100 years or so we'll experience a earthquake that causes property damage. And major transportation accidents have become increasingly rare in the U.S. due to just stringent safety hazards. Probably the main threat that people talk about now is pandemic flu. This is really a global disease outbreak in which people have lost immunity or don't have immunity to the flu, and it causes rapid spread and the potential for large loss of life. The major pandemic flu that hit in the U.S. was in 1918, and I think there were something on the order of 650,000 deaths caused by the pandemic flu. The concern that there's still vulnerabilities to pandemic flu, so this is a major emphasis of disaster planners now. So with all these things out there that can present hazards and threats, how do we know what to focus on? So what's really needed is an all-hazard approach. This just takes into account that all these things are out there and that we need a management strategy that can identify them and leaves us prepared for all of them. So the CDC did this campaign which kind of takes all hazard approaches to another level, and that was really about a zombie apocalypse. So although zombie apocalypse may be something in just fantasy or imagination, the idea was that if people could get ready for zombies, they could get ready for tornadoes or for earthquakes. So the social media campaign that went along with this was extremely popular, and I think at one point it caused one of the servers at CDC to crash. So they still have comic books and posters that are available for download at the CDC if people are interested. So how do we know what to get ready for? And that's really based on what's called a hazard vulnerability analysis. This is a needs assessment that is done by organizations to decide which risk is the greatest. And it's really a calculation based on the probability of event happening multiplied by the severity of the event. If it does happen, how much damage would it cause? And the severity is really a function of the impact minus your ability to prepare and respond for it. So getting back to the emergency management cycle. And the threat increases with the percentage. So the hazard vulnerability analysis allows you to recognize the hazards that you may not have thought were the major ones. because they may have kind of been off the radar screen. It's something that we go through annually in the hospital that I work at, and we break threats down into external hazards and internal hazards. We felt that severe weather was the major threat externally, and so this came down to tornadoes and ice storms, snow. And sure enough, not long after doing our hazard vulnerability analysis, we had a snowstorm. It may not seem like much to people in the other parts of the country, but 6 inches of snow was enough to trap all the hospital staff in the hospital for days, and really kind of threw a whole monkey wrench into the organization. But we were ready for it because of the hazard vulnerability analysis. Our major internal threat we found was just unauthorized visitors or unauthorized persons going through the hospital. This is a common occurrence, so the probability of it happening is actually pretty high. So identifying it as our leading internal threat allowed us to plan drills for it and to come up with procedures so that we were more aware of the problem and had extra security precautions and procedures in place to deal with it. So the hazard vulnerability analysis is really the foundation of emergency planning. Now, to switch gears, I'll talk about personal preparedness. Personal preparedness involves mainly two elements, and that's stockpiling, so getting supplies ready, such as getting a disaster kit in the home or having extra supplies in the hospital to deal with a surge of patients. So stockpiling is the first element, and the second element is planning. So that involves what to do during a disaster, how to take care of patients or how to take care of your family, where you might meet. The third element that people add is staying informed. So having a way to stay informed, knowing what's going on in your environment. So those are the three main elements: stockpiling, planning, and awareness. When we talk about vulnerable populations, these are really anybody who needs extra assistance during a disaster. Primarily it's the elderly and the children, but it can also be people who have communication problems, mobility problems, difficulty maintaining independence, speech or language barriers, and then transportation problems. Depending on how you define vulnerable populations, this can be half of the U.S. population. So half of the population could be at greater risk during disasters, and plans need to account for that. Healthcare workers and responders are probably a special class because those are the people that will have to be on the front lines of managing disasters. So some of the thoughts are, how prepared are people? When you look at most of the data on personal preparedness, it seems that probably about a third of people, or 25% of people, have met basic stockpiling and planning elements. So they have a family plan, or they have a plan for their business, a continuity of operations plan. Typically it's around about a third of families that are able to do this. And it's not much different for healthcare workers, unfortunately. You know, despite increased awareness of the threats and the fact that we may be called on to respond, most healthcare workers still don't seem to be prepared for disasters. These are just some of the items that are needed for stockpiling, and if you look at them, you can see that there are some barriers to obtaining 72 hours worth of supplies, which is the current recommendation. So depending on how large the family that you have is, there's financial barriers, there's space barriers, and what we call competing priorities. Everybody has busy lives, and trying to find time to gather supplies, trying to find the money and resources to do it can be a challenge. Even more difficult than stockpiling resources is really planning. And for plans to be most effective, they really should be written down. The first form that you see on the right is one that had been advocated by the American Academy of Pediatrics and the College of Emergency Physicians. And this is a form for families to use to fill out, especially if they have kids with special health care needs or medical needs, that they can fill the medications out and then keep it up to date. The second form is put out by FEMA and ready.gov, and that is a family emergency plan and communication plan so that families can fill out how they're going to reunify in case they're separated during a disaster. These are available for download on those websites, and I'd encourage families to go ahead and fill them out and make sure that the kids know too where they will meet up with the family in case they're separated. There should be a reunification place within the neighborhood and then within the community. And they should have a couple of contact numbers that they can reach. In 2006, the Institute of Medicine came out with the future of emergency care, and they made this comment that while children have increased vulnerability to disasters, disaster planning has largely overlooked their needs. So what did they mean by that? Well, pediatric patients have unique vulnerabilities. They're not just little adults. They have different developmental features, so they tend to be dependent on caregivers. They have communication barriers. They may actually run towards danger. So they have developmental issues, developmental features that put them at risk during disasters. And they have anatomical features that means that their equipment needs to be specialized, their drug dosing needs to be weight-based, and they have body size and surface areas that puts them at risk to heat, to gases, to all sorts of hazards that may come out in an environment in disaster setting. Finally, they have physiologic requirements that are different than adult. They have different metabolism, different food requirements, and disaster planning needs to take those into account. We talk about the healthcare system as a whole leaving children vulnerable during disasters, and this is kind of what we say is the 75-10% rule. Roughly a quarter of the population in the U.S. are children, but since kids are primarily healthy, only about 10% of the hospital beds are dedicated to taking care of kids. So this sets up a disconnect when there's a large surge of patients. There may not be enough beds for kids. This is especially true for critical care, for things like burn care, where it's even harder to find beds. Typically, most hospitals are run at about 70 to 80% capacity, especially in the critical care areas. This is true for children's hospitals especially. So that leaves very little reserve, and that sets the whole healthcare system up as a whole for vulnerabilities if children are affected. Several years ago, the National Commission on Children in Disasters was formed. This was a bipartisan, independent body created by the first President Bush to do a needs assessment for what kids need during disasters and what is actually out there, what's known, to take a look at the literature and find out what's known for caring for kids during disasters. So it was formed in 2007. They came out with the first report in 2009 and the final report in 2010. So we're 4 years out, and most of the final report has started to get integrated into disaster planning. What they looked at, so a comprehensive needs assessment and looking at what's needed after disasters for kids. And it highlighted several areas like disaster management and recovery. And they recommended that kids be identified as a separate at-risk group from other vulnerable populations. So FEMA set up these child integration specialists at the regional levels. In terms of what's called CBRNE, there's been an emphasis on ensuring that pediatrics have adequate and appropriate medical countermeasures for things like radiation events and chemical and biological outbreaks. So these have started to be integrated and formalized. They've also recommended that the creation of regionalized pediatric systems to augment a surge of children during disasters. Other areas that were looked into included housing, evacuation, sheltering, mental health, and child welfare and education. So now I'll switch gears and talk about some pre-hospital issues. Mass casualty events involving children are actually pretty rare, and this is where the healthcare needs exceed the resources. This can occur at a local level or at a regional state level. Now, back in April of 2011, there was a large tornado outbreak in the southeast. And one of the largest tornadoes, an EF5 tornado with wind speeds over 200 miles an hour, hit Tuscaloosa, Alabama. This resulted in a large surge of pediatric patients. And over 20 of these kids were taken from Tuscaloosa to the tertiary care center in Birmingham, which is roughly an hour away. Now, because of the weather, the critical care teams that typically transport children who are seriously ill could not fly. So all these kids were transported by ground ambulances and using just general EMS services. This was augmented through the state EMS agency trauma routing system that allowed them to cross typical jurisdictional boundaries. And what we found is that when researchers looked at it, they found that they actually did a very good job, that there were no adverse events in the resuscitation or the transport phases of care, and that adequate stockpiles of supplies existed. So all these kids got to tertiary care safely. So they did identify some opportunities for improvement, and most of those things have kind of been taken into account, and I'll talk about many of them later. So Dr. Cantor, who did this study, kind of made the comment that successful responses to the Tuscaloosa tornado serve as a challenge to all of us. How many regions could match Alabama's performance? So actually, I think it went pretty well, and we'll kind of use that as a case study here in just a bit. This program is brought to you by the EMS for Children program, who has been instrumental in disaster preparedness for kids. They have two ongoing projects. One is a National Pediatric Readiness Project, which is really doing a needs assessment for hospitals at a local level, and this will be nationwide, to find out how prepared they are to take care of kids and to handle a surge of kids. They also run a clearinghouse for pediatric resources called Ped Prepared. If you haven't seen that, I'd recommend that you look at it. It has a whole bunch of resources that can be used for planning for kids in disasters. Another report that has been ongoing over the last 6 years has been done by Save the Children. They've looked at children in schools and daycare, and they've identified 4 core measures. The first is, do daycares and schools, are they required to have written evacuation relocation plans for all students? Do they have family-child reunification plans? So if a disaster and event occurs, do schools and daycares have written ways that they're going to reunify families? And do they have special plans for kids who need extra medical care or have special needs? The other thing is, in schools, K through 12, are they required to have multiple disaster plans? And these, again, have to be written. So they've looked at what states, if they've met these 4 core measures. Here in Alabama, I think we were one of the first states to actually meet all 4 of those measures. But currently, only 22 out of the 50 states have met these. So there's still a ways to go to get all the states on board with disaster planning. So I'd encourage you to look at their website and find out how your state's doing. Now, switching gears, once again, we'll talk about post-disaster mental health issues. Teresa mentioned that after a disaster happens, children have special medical needs. The main things that we see happens are injuries spike, mental health conditions can exacerbate. We know that child abuse escalates after major disasters. School absenteeism typically goes up about 8 or 10% in regions after a natural disaster. We also know that post-traumatic stress disorder, depression, and anxiety can all increase, and that adolescents are at risk for substance abuse following natural disasters. The major determinants seem to be how well parents respond. So if parents respond and are resilient, then kids generally do much better. And also the degree of exposure. We think that families that have immediate loss or loss of property are at higher risk. So pre-existing conditions, children and adolescents that have pre-existing mental health conditions almost are often at higher risk for having exacerbations of those conditions, things like ADHD, sleep problems, depression. The age at which children experience these also seems to affect their condition. The younger kids seem to have a worse time. Adolescents oftentimes become withdrawn following natural disasters. Mitigating factors, one is early support and intervention, and then a return to normalcy, especially getting back to schools. An interesting a qualitative study was done following the Joplin tornado, in which half of the schools in that district were damaged or destroyed. Now what Joplin did, this tornado happened in May, right at the end of school year. What they did was set up temporary school buildings, tried to get kids back into school, started summer school programs that focused rather on instead of focusing on academics, tried to get them back into a reassuring, supportive environment, and then allow for a needs assessment. And then school started on time in the spring, which was key. And all kids went back to the same school that they would have been in, even if their family relocated. And although it's hard to measure, qualitatively it seemed like that resulted in better outcomes for the kids, for the community as a whole. So those were all recommendations that came out with the Presidential Commission and that were used during the Joplin tornado. So kudos to that school district on their efforts. So after Hurricane Katrina, there were over 5,000 kids that were displaced and separated from their caregivers. It took 7 months to reunite them. So in 2006, the National Emergency Family Registry and Locator Center was opened. This is something that's run in conjunction with the National Center for Missing and Exploited Children and FEMA. During times of natural disaster with widespread displacement, FEMA takes it over, but I think during routine domestic operations, it's run by the Center for Missing and Exploited Children. There's interest now in web-based biometric technology for allowing this to be sort of a novel technology to facilitate reunification of families. And this involves collecting some biometric data and allowing families to have better access to identifying children.
Are you speaking specifically of like fingerprints and DNA and things like that for the children?
Yeah, I think I've seen studies that look at things like facial recognition. That's the main one that I'm familiar with. Now I'll talk about hospital issues, and that mainly comes down to surge capacity, where there's a large increase in the number of patients that are seeking care. So this may require sort of a paradigm shift. We're used to doing everything for everybody in the emergency department, but this may mean that we have to kind of shift gears and look at the community as a whole and prioritizing care. When we talk about surge capacity, we usually look at four main elements. That is staff, having enough staff on hand to carry out a surge, to manage a surge, having enough supplies or equipment, where are we going to do it, and how are we going to do it. So those are the main elements of surge. And I talked about a paradigm shift. This is a subject of debate in the emergency literature currently, and some people think that, still focusing on the individual patient is probably the best plan. So I think it really depends on the patient numbers that come out. True surge events are relatively uncommon. As we develop increased capacity and resilience of our organization, we find that we're better able to handle shorter surges of patients. So I talked about the incident command structure earlier when I was talking about NIMS. And since hospitals are our first receivers for patients, we're required to have an incident command structure. And this involves having an on-scene management team that can be put into place to manage an event. So all hospitals have this. This is a Joint Commission standard. I know the text is too small to read, but most of you should be familiar with that and should have at least an idea that the structure is in place in your hospital. A new emphasis on regionalization of response. Again, I mentioned the rule that only 10% of hospitals or beds are dedicated to peds, but kids make up about a quarter of the population. So we find that in critical care it's even more so. So the proposed solution is to create a network of children's hospitals to manage a large regional surge event, something like a hurricane, earthquake, or a tornado, in which there's a lot of kids that need care and need tertiary care. So there's several regions that are looking at this now, and in the southeast we have what's called the Southeastern Regional Pediatric Disaster Surge Network. This now involves, I think, about 5 or 6 states, and 40 private organizations, all of which are trying to work together to share resources in the event of a large disaster and to facilitate transfer of patients should capacity at one of the facilities be overwhelmed. And it's really a voluntary network that is looking to improve preparedness strategy in the event of large-scale disasters. So the network's gone through 3 phases here in the southeast and is currently on the phase 3 of a long-term formalized linkages of organizations so that we have memoranda of understanding, we know how to transfer patients, and then finally testing and knowing if it actually works. So this has been a major emphasis nationwide, and it's, I think, probably going to be the way that large-scale disasters are managed for kids. So what I really wanted to focus on was a case study, how we managed a tornado response back in April of 2011 with the Tuscaloosa tornado. So I think at this point I was going to show a video clip. Do we have that clip?
We had a multiple vortex tornado on the ground. There it is. You can see the multiple vortexes and vortices that are rotating around the common center. Span a little to the left, and we'll get that thing centered. This is a large multiple vortex tornado that is almost into downtown Tuscaloosa. And again, you should have been in your safe place 20 minutes ago. But if by chance you're hearing me at the last minute on the radio, get into a safe place right now. Small, underground if you can. No underground, first floor, small room, lowest floor, near the center, away from windows. While you're looking at that, don't forget we have a possible tornado, could be a large one, that's moving up into Marion County, out of Lamar County. Another one that's passing way north of downtown Birmingham, affecting the far western tip of Blount County. It's moving from Sipsey and Empire. Look at the debris. Look at the debris in that. Zoom in tighter, Jason, if we can go in tighter. Look at that. Goodness gracious. This will be a day that will go down in state history. And all you can do is pray for those people.
All right. Well, that actually was 3 days of tornado outbreak that really occurred from the southeast all the way up to Canada. I think it affected 21 states in total. And during those 3 days, there were 355 tornadoes that were formed. In Alabama, we had 4 EF5s that were formed during that. And here in the state, it cost $11 billion in property damage, and we had 238 of the total 355 deaths that occurred during those 3 days. So 238 deaths due to those tornadoes. And on the main day, on April 27th, it actually was a series of tornadoes that kind of started in the morning. And not far from my house, maybe a mile from my house, was the first one that hit, was EF1. Primarily property damage, but I think a few adult injuries occurred during that. So we were already on heightened awareness that day. So by the afternoon, the meteorologists were saying that this was going to be a very bad night. So we'd called in extra people. We'd already reorganized into teams. So when that tornado hit Tuscaloosa, which is a major metropolitan area here in Alabama, we knew that it was going to be a very busy night. So we stood up our hospital incident command center. We used the paging system to call in extra people and to notify resources, things like a blood bank and the chaplains, interpreters, security, administration. So to get all those things ready and into place. And then in the emergency room, we broke up into special teams and decided how we were going to allocate patients. The ICU tried to move as many patients as they could out to free up room. We had a stockpile of extra ventilators that we actually deployed during this. And we did establish an alternate care site, off-site. So all that happened in the matter of really, an hour or two where we were able to get those things going. And the reason that we were able to do that is because we drilled it and planned it. And we knew that this was a possibility based on our hazard vulnerability analysis. So all these resources got mobilized relatively quickly. So we were ready. So, and what we saw was we had 60 disaster patients. Most of these came in the first 8 or 12 hours. We had what we called a code yellow at the time, which was our disaster plan. And that went on for, I think, about 11 hours. So most of the patients came in that first time frame. The age range was 2 weeks to 18 years. Almost all of them came in by EMS services, a few by private vehicle. Of those patients, 42 were admitted. 1 died in the emergency room, and 1 died in the hospital. 21 patients were actually able to be discharged. The numbers I know don't add up to 60 because not all of them were counted as disaster patients because they kind of came in after that initial code yellow was stood down. 9 of them were admitted to the step-down unit or the special care unit. 1 child wound up staying in the hospital over, I think it wound up to be about 4 or 5 months. And we also had multiple tornado related non-disaster patients, things like mental health visits that aren't counted in there. While this was going on, we still had the usual things that we see. We still had kids with breathing disorders, asthma, appendicitis, shunt malfunctions. So all these things had to continue. We couldn't put a hold on any of those just to take care of the disaster patients. So we needed extra staff, supplies, space, all those things. What we found was primarily head injuries, orthopedic injuries, and soft tissue injuries. This is something that's been seen in tornadoes in the past and really wasn't unique to what we saw. So we kind of expected most of this. Now, I told you that kids have unique vulnerabilities during disasters. And one of the anatomical features is that they have large heads, so they tend to get thrown very easily. It's usually head injuries that cause the major morbidity and deaths in kids. And this is a typical injury that was seen during that time frame. So this is a child with a depressed skull fracture and intracranial bleeding. So intracranial hemorrhage with a depressed skull fracture. And this is from being thrown against a solid object, a wall, or a solid object flying through the air, a projectile, and then hitting the child's head. This case was a 7-year-old. This child came in and wound up going to the operating room. I think there were a total of 12 craniotomies that were done in the first day after this tornado. Some of them were done that same night. This child was then admitted to the intensive care unit and eventually made a full recovery, which is the case that if kids can get to critical care in a timely fashion, they usually have a good outcome. So one more case, and this is one that I actually saw of an older child who was 10, and this child was found in a field. The parents had unfortunately died, and his sister had died during this too. This is, again, a depressed skull fracture with intracranial swelling and bleeding. This is a lot of swelling, so this probably represents a hypoxic type injury, or a child that has been injured and then is down for a certain amount of time. So because that's a secondary injury, that hypoxic injury is much more difficult to treat. So that child, I think, actually had a developmental injury or delay after that. The other thing that we saw was orthopedic and soft tissue injuries. So this is a common injury from a tornado. This is a femur fracture. The femur is the largest, strongest bone in the body, but it was frequently broken. I think there were over 20 orthopedic cases in that first day, primarily setting of femur fractures and long bone injuries. We also saw a lot of soft tissue injuries, primarily of the scalp. So when projectiles hit the scalp, and I think there were about a dozen scalp washouts that were done in the emergency room. And a few of them went to the OR that night, but because of resources, many of them couldn't get a washout in the operating room due to lack of staff that night. So some of these kids were admitted and then got a delayed washout. And some of them were washed out in the emergency room, and a few of them actually came back with delayed infections. That's something that's been seen after disasters and are similar to actually kind of like combat wounds because they tend to involve a lot of dirt and debris. It's really hard to get this high impact debris out of the soft tissue. So if at all possible, we're now trying to do like delayed closure and an operative washout for these sort of injuries. We also saw quite a few patients in the following days with things that are commonly seen after disasters. Carbon monoxide poisoning is well documented after almost every natural disaster. When people get out their pressure washers, when they use camp stoves, when they use generators and don't ventilate properly. So we had a couple of carbon monoxide poisonings that we saw. We had 2 children that were seriously burned from candle fires. So candle fires are a major problem after natural disasters. And then several puncture wounds, injuries, chainsaw injuries, and then mental health exacerbations. This was a picture taken by one of my colleagues. She's a nurse in the emergency room, and this is actually her neighborhood. So this is kind of, you can get an idea of the impact that these things cause and debris flying. There was a home right here by that car that's now gone. So what we learned when we looked at our after action plan, when we all came together in the hospital and did it, is that the code language that we were using didn't work very well. So saying code yellow was confusing to people. So, and even saying code T was confusing to people. So now we've revised that and we say severe weather alert, severe weather stand up, so that people know exactly what they're supposed to do. So we tried to get away from like code language and use plain talk, which is part of NIMS, to use plain talk. We felt that the incident command structure wasn't very well integrated at the time. Like even a lot of the administration really wasn't clear on how to use it or what to do. But I think we've come a long way in the following years, to actually having tested it and know that it works and that we can deploy it. We found out that we had limited capacity to care for seriously injured kids, even with extra supplies on hand. At the time, the ICU was, I think, about 32 beds. If we had just a couple more kids, we would have exceeded capacity and likely have had to transfer kids to outlying facilities. And there was talk about actually deploying or utilizing the surge network that was in the creation stage at that time. But we didn't have to use it. We were able to kind of move things around. Now we have more capacity. We have a new hospital. We have a larger ICU. So our capacity is even greater now. And we think that, the more you test these things, the more you utilize them, the greater your ability to expand capacity. The trauma system in Alabama worked very well, again, just like it did for tornado, I think back in 98 or 2002 when it was first created. It helped to route kids and get them where they needed to quickly. We used our electronic medical record system in the emergency room, and we felt that throughout the hospital stay that really helped facilitate care. So as much as we could, we tried to keep doing what we were doing, just ramp it up, do it a little better, so to speak. So in terms of documentation, sticking with the electronic medical record systems. The other thing that we found out in the hospital is that our reunification plans, we do them every day. We have to reunify families after auto accidents, after injuries, when children come in unaccompanied. So we were used to that, and calling in chaplains and social workers facilitated this. It took about a day to get all the kids reunited with their families. Looking over some of the injuries, we really identified that kids seem to be safer if they're using helmets, if they're infants, if they have car seats. I had 3 patients that we saw in the emergency room. 2 of these were infants that were in infant carriers, both in the neighborhood of near Birmingham. One of them was a 2-week-old, one of them was a 9-week-old. The families put them in carriers to move them around, but found that when the roof went off of one of the houses, the family was just able to lie over the infant carrier and protect the baby easier. The other one was actually a house collapse and a cave-in that the infant carrier held up the part of the wall that had fallen and actually had crushed the mother. So the child's mother had died on the scene, but the child was safe in the infant carrier. So we think that those are probably a good idea for young kids, and the father of that infant actually said that he thought that it saved his child's life. I'll talk a little bit more about helmets when I tell you, show you a picture and a story of a child that I met. But we felt like a greater emphasis should be placed on post-disaster safety, safe use of generators, of camp stoves, and avoidance of candles after disasters. And then improvements in early warning systems, things like smartphones, social media, to try to get the message out. Overall, I think in Alabama they did a great job of getting the message out. Just like our meteorologist that you heard, he's sort of a local hero here, but he said you should have been in your safe place 20 minutes ago. So these don't come without warning. You know, generally there's a lead time, so people have time to kind of get in their safe place to gather supplies, where they don't for earthquakes. They do for tornadoes and hurricanes, things like that. So injury prevention can be a greater part of preparing for tornadoes. Some of my colleagues had mentioned that they really wish that they had their hard-soled shoes with them and that they'd had their ID on them so they could get back in their neighborhoods after the event, and that they'd charge their cell phone before things started to get crazy. So those are kind of messages that people need probably earlier in the day. And this is the same neighborhood just in just outside of Birmingham that experienced the EF4 tornado. This is a young 9-year-old boy, Noah Stewart, that we saw in the emergency room. He actually was in that same neighborhood in Pleasant Grove, Alabama. And his mother, who is a nurse, had told him to put on his baseball helmet. It had a face shield and a chin strap. So he put that on, and the tornado hit their neighborhood. They were in their safe place, but it still destroyed their house, lifted him up about 30 feet in the air, and he was found 150 feet away from the house. So he was thrown a long way. The helmet was never recovered, but he came into the emergency room and really just had some scrapes and bruises. He had a few x-rays done, a few lab tests, and everything turned out fine. So he was discharged. And although the family's house was destroyed, he was fine. So he's actually been a big proponent of utilizing helmets. And I'll just show you a kit that some of the nurses, so after this happened, some of the nurses at the hospital got together and came up with some what's called a severe weather kit. So this is, and then a checklist. So the hospital where I work at hands these out to families and has handed them out at ball games and community events. And it has a checklist of things that people should do to get prepared for severe weather. And inside of it, it also has what one of the nurses I thought was pretty ingenious that came up with this. She said that her kids have bands, so she writes the name, the phone number, and then medications and allergies on there, and then it's like a slap band. So, whoop, wrong way. So you just put it on, and she has them for each of the kids. So we've started to pass those out, and again, I think it gets back to the preparedness aspect, that if you can get people to do some planning, then they're much more excited about getting ready, and they take greater awareness. So this was the disaster kit. And in terms of helmets, there's another group at UAB that was looked at the patients that were injured, including adults, and found that of the deaths in Alabama, almost all of them occurred because of head injury and C-spine injury. So they've been advocating helmets too. And then this kind of got picked up on the media, and the CDC actually kind of advocated or changed their message to include helmet use, provided that people have enough time to do that. And again, for tornadoes, you usually have a lead time of 20 minutes or more. So I think it's a smart part of a family disaster plan. So that's one of the things that we've done. So I just want to end on this point of resilience. So resilience is something that's got a lot of attention in disaster circles. It's defined as the ability to take a punch and keep standing. So I think probably the best formula for resilience is your ability to mitigate a disaster plus your ability to prepare for a disaster. So if you feel like you can prepare for it, and then how good you are at responding to it and recovering from it. So essentially, resilience is your emergency management cycle. So the better you get at your emergency management cycle, the more resilient you are. So as a family, the more prepared you are, likely the more resilient you will be. So, things like disaster kits, disaster planning, probably makes for increased resiliency among families, and then certainly among healthcare institutions and agencies. The more planning that you can do, the better you can mitigate against disasters, the more resilient you'll be. So this is really the principal goal in managing the critical functions in an emergency. And it gets back to that emergency management cycle that I talked about. So that's pretty much it. So I want to tell you, ways that you can get prepared. You can look them up, through Alabama Department of Public Health has a great website on personal preparedness. So does ready.gov has just about anything you could need for personal preparedness, the supplies you might need, how to do personal planning, how to come up with a communication plan for your family. You can join a state or federal response team if you have an interest in doing actually disaster response. Red Cross organizations like that are always up for having people that are motivated to help respond. And then if you want to learn more, you can take independent study courses through FEMA, through their emergency management agency. And I know that they recently funded a 16-hour course in pediatric emergency response. It's primarily for emergency managers and planners. It doesn't go over so much medical, but I think it's more for emergency managers, so how they can get ready for pediatric disasters. So that's available too, and I think that's through the Texas A&M Extension Services. You could find that probably just through a Google search. But if anybody has any questions, I'll be happy to answer them. Feel free to email me. There's my email contact. And thank you again for your time and for your interest in this topic. I appreciate everybody taking the time to come out and listen to this. Thank you so much.
Dr. Baker, we really do appreciate your information, your knowledge, your willingness to share. We've got a couple of questions if you would be willing to entertain those questions.
Absolutely.
Valerie's going to read those for us and we can respond.
Okay. First of all, can you talk about the staff response to the tornado in Tuscaloosa? I can imagine that some staff were not able to come to the hospital due to the roads being blocked, and other staff may have had to choose between staying with their family and helping neighbors rather than reporting to work. Did that add to the problem of being short-staffed in the ER or the OR?
That is an excellent question. What we found is that, we had some lead time. So I was on an evening shift, so I kind of sensed that something was up. So got in early, and Tuscaloosa is an hour away from Birmingham. So what we found, enough staff lived close enough by that I was able to contact people to come in. And this was probably best done at a unit level. So the neurosurgeons that I work with, they published a paper recently that kind of outlined their experience too. And they called in an extra team. They felt like it was vitally important that they had people that were well rested and ready to relieve them the next day. So you don't want people working too long, too hard. The adrenaline's going during these things, and everybody wants to help. So it was actually the case that we told people, hey, stay at home. Why don't you come in at 4 a.m. or why don't you come in at 5 a.m. early and come in and take over, okay? And that would be much more helpful than coming in now where we have extra people on hand. Because once people start to get tired, they make mistakes. So you really need to work on operational periods and keep them, short, 8, 12 hours, certainly for medical people, is plenty. And in a high-stress environment, rotating the staff is really key. So roads were a problem, especially in the western part of the state early on, but for people that lived in the metro area, we knew that this was happening outside, and there were enough people that were able and ready to come in that if people felt like they needed to stay with their family, that was the best place for them. So we had the luxury of having extra people. Now, actually in Tuscaloosa, staff members walked into the hospital. The tornadoes hit, you know, a quarter mile from the hospital, and staff walked in and took care of patients. So when they found that there was a large surge. Thank you for the question.
One more. Has there been an increase in community preparedness education activities at schools and other places in the community?
I think there has. It's hard to measure, but certainly there's been increased awareness. Now, I know of several community activists and advocates that had on their own gotten grants to purchase helmets and distributed them at the minor league baseball games and at school fairs and events, and had on their own spoken just because their communities were affected, and they felt like this is something tangible that they could do. Do I think it's like the complete answer? I don't, but I think that it engages the community, and the more you have a community that's engaged, interacting, the better able they are to respond and more resilient they are. So I applaud like all those outside efforts, and so yeah, I think that we did, and I think that it really heightened the community preparedness to actually test out how prepared we are.
That's the only two questions I have.
Thank you very much for your time and your willingness to share. Give us, if you will, Dr. Baker, 3 take-home points, if you can, to just kind of summarize what you've given us today so we can remember. You know, you tell them what you want to tell them, and then you tell them again.
Thank you. Yeah.
So give us, if you will, 3 take-home points.
Yeah, the key take-home points are your ability to respond to disasters really depends on your personal level of preparedness and your awareness of what's going on. So find a way to get prepared, to stay aware of what's going on, and stay engaged in your community and hospital efforts for whatever your risks are. And whatever your risks are really depends on where you live and what you're doing. So those are the main messages that I'd like to send people home with today. And thank you again.
Thank you. We've got, it looks like we have any questions from the audience members as well. We have one.
What type of helmet do you recommend for children?
That's a great question. You know, I think the best type is the type that you have ready, that you have ready. You know, I don't think that people need to go out and buy extra supplies. Almost everybody has a bike helmet ready, and you know, just a typical like helmet like this is a good one. You know, it's just, it won't protect the face, but you know, these are rare events. And what you really want is just that extra bit of security and ability to protect the head. So most people, what we recommend is that if you know that something's coming in your area, you know, because you've stayed aware, you've watched the meteorologist, you've watched TV, or you listen to the radio, that's when you go and you get your helmet from the bike, from the garage, or from your toy chest, and then you bring it into the safe room. And the safe room is the central, lowest, sturdiest place in the house, in a sturdy structure. Okay, that's when you go get it. You don't go get it, you know, during the crisis. Okay, during the crisis, you just need to get in your safe place. Okay, but I think any kind works. Noah Stewart, that boy, he had probably an optimal helmet because it had a face shield on it too. It has something to protect the face. But whatever you have, I think, is great. So, and almost all kids should have a bike helmet. If they don't, get a bike helmet. Right? That's preparedness for, you know, daily life. So,
Any other audience questions? We have one more from
An
email.
Yes. During a disaster, the response vehicles are often overwhelmed and not able to handle the need. Can you describe how community members assisted in bringing patients to the ER, and what is the position of the hospital in having patients being brought in cars and trucks?
that's another great question. What we saw was that, at least from Tuscaloosa and from northwest Alabama later on in the night, is that ambulances were bringing in multiple patients. They would usually have 2 patients in an ambulance. You know, and kids are smaller than adults, so you can usually transport several of them at the same time. They would oftentimes have one that was critically ill and one that was less severely injured but needed care. So say one child with a head injury who is seriously ill, and then one with an extremity fracture who, you know, doesn't necessarily need, you know, full C-spine immobilization, but needs transport. So they were able to reroute and get around most of these hazards. I think it took longer for most of the ambulances to get in from their destination because trees were blocking and they had to reroute in many cases. The other thing that was seen is that community members would transport some people in pickup trucks. That happened, I think, more in Tuscaloosa, where the greatest damage occurred, than in the Birmingham metro area. But we saw several kids that were brought in by personal vehicles. The question is, do we have a policy about it? Not really in the emergency room. We'll take whoever shows up, you know. And, you know, as long as they can get there safely, that's optimal. During these kind of storms, transportation by critical care services usually cannot occur because they're overwhelmed quickly. So, you know, you do the best that you can, and we're happy however patients get in.
Dr. Baker, we have a call. Would you care to
Sure.
take that, please?
The call is from Iowa.
Iowa.
Hello, Iowa.
Hi. My question is, as far as the kit that you had that the nurses did for the emergency pediatrics, you mentioned the wristband, but I was wondering what other items you had in that kit that you could share or listed.
Yeah, I'll be happy to. So it says parents need to pack other supplies, and it gives a website for ready.gov tornadoes, and it says for preparedness and long-term supply kit suggestions. And in the event of severe weather, stay tuned to a local weather channel or radio, okay? And then it talks about everybody should have a programmed battery-powered weather radio, and then it gives other tips. And then here's a tornado safety checklist that basically has people pre-identify their safe room, has them pick an area in their neighborhood where they'll reunify, and then an area outside their neighborhood where the family can get together if they're already separated. And then gives an emergency supply kit, things that they recommend in here. It says my helmet, my flashlight, my shoes, my name band. Make sure parents fill in all blanks. It should include name, birth date, allergies, medications, emergency contact name, and number. Now, this was all done by like the nurses at Children's of Alabama. They kind of took this initiative and they asked me for suggestions, and I thought what they did was great. So it's a nice, simple, concise message. You know, basically says, have these things, know where your safe place is, know where to get there, and then have a way to reunify. So it kind of gives the whole preparedness message right there. So I think it's something that your hospital could duplicate very easily. I'd be happy to share you the contact names and number, and maybe you know, our people could supply you with a sample, or let you have one of these too. I know they offer them for people who show up to the hospital and request one.
Thank you.
Any other questions?
I've got a couple more.
Great, great. You're a hot topic today, Dr. Baker.
We've not had this many questions in a while. Tell us what if y'all have seen anything as far as using like a mattress over your head in the bathtub. You know, that's the old-timey thing that we've always heard is put a mattress over your head. Do you think that helps?
I heard about that. You know, I don't think any of the kids, going back over the records, I don't think any of the families did that. One of the the 2-week-old, the family kind of laid over the infant carrier. But I saw reports that adults had done that, and I know that that's been done successfully. You know, again, it's been recommended that you find this internal room, lowest one, as your safe place, and that you cover your head with blankets or something sturdy. I think that those are wise things to do. Again, it's not something you want to do, you know, at the very last minute. The very last minute you need to be where you're most safe. Sometimes that might be the bathtub, sometimes it might be under the bed, but I've seen reports of all those, and it's really hard to give, you know, concrete evidence-based recommendations on these things because they are rare events. Cumulatively, they're not rare. You know, I told you several hundred tornadoes every year can be predicted, and you know, maybe 10% of those will be strong to violent tornadoes. So they're rare events, but it's not the sort of things that you can design studies for. See, anecdotal evidence is probably about as strong as we're going to get for a lot of these things. But for me, I think that they work. And again, you know, people do the best. If you don't have a safe place in your home, you need to know that beforehand, and you need to be able to get to a safe shelter. So a neighbor or a community pre-designated shelter, and need to stay even more aware than everybody else is. So that's, you know, people that live in structures that are less safe, things like mobile homes and less sturdy structures.
Got a couple more questions coming in. Did any community members show up at the hospital to help during the first few hours after the tornado? Was that allowed? And are there liability issues with untrained staff and volunteers during the disaster?
That's a great question. You know, at Children's Hospital, Children's of Alabama, we don't really have volunteers for these sort of disaster events, unless they're, you know, already pre-screened and pre-credentialed. So everybody has to be credentialed and pre-screened. So there's a movement among state agencies, Red Cross, everything to get people pre-screened and pre-identified as disaster responders. What we've often found is that, you know, spontaneous, unsolicited volunteers can kind of bog down the disaster response. It can be helpful in some ways, but a lot of extra supplies or people that aren't trained can pose a hazard. So I think in the following days we had many people that had requested help, but we had enough staff that I think they were able to kind of channel those requests into community organizations that were better able to utilize their services or their volunteer actions.
And I will tell you, Dr. Baker, that here at the State Health Department, we do have a volunteer database, and we do encourage people to register as a volunteer.
Absolutely. If you think that you might want to volunteer in your state, I would look up the state volunteer registry and do that and submit your credentials so that things are expedited in the event of a disaster, because a lot of people want to help, but we really need to know what people's level of training and skills are and how best they can be utilized in the response. So go to your state Department of Public Health and look up how you can get pre-credentialed to volunteer.
Yes, sir.
And I think I mentioned that in one of the closing slides, but I think that's really, really key.
Yes, sir. I agree. A question coming from Wisconsin: what age range on infant would you recommend to be in a car seat?
Oh, that's a great question. I think, you know, up to walking age. If you put your child in an infant carrier, and that's probably under 6 months, that's probably a good age. You know, getting a car seat out of a car may not be the best thing to do because car seats are difficult to put into a car. So it's probably best to get it in there securely and leave it in there. And if your child's big enough that they don't need an infant carrier, then they probably are best served by, you know, just being in that safe place, perhaps with a helmet, as they get a little bit older. Okay, so, you know, 6 months or so, I think after 6 months, kids get pretty heavy to lug around in a carrier.
Yeah, that's good advice. That's all questions from the
Thanks
email.
again.
Thank you.
Thank you. We appreciate it very much.